Welcome to the second video on Chapter 8. So we're going to finish up talking about touch perception, pain perception, and we're also going to talk about some unusual sensory experiences such as synesthesia. So talking about normal perception and also abnormal perception, not in a way that's disordered, but just a different way of perceiving things. So for touch, the primary somatosensory cortex lies in the parietal cortex, right on the border with the frontal lobe. So it's actually just behind the central sulcus, which you'll see here. So it receives touch information from the thalamus for the opposite side of the body. So the right side, primary somatosensory cortex, receives the information from the left side of the body. There's also a secondary somatosensory cortex, which you'll see right here. It's actually quite small. And it's a little bit different because it actually maps both sides of the body instead of just one. And you'll see this on the next slide where the areas that are mapped in this area are much less laterally specific. So certain areas of the body are more sensitive, in part because they have more receptors. This corresponds to larger areas of the cortex being devoted to them and devoted to processing all this additional information. So notice all the space that's allotted to the face and to the hands in comparison to the leg, for instance, which is much larger in size but doesn't have nearly the sensitivity that the hands have. Another way to visualize this is the homunculus, which is this guy here, in which the parts of the body are shown in relation to how large they are represented in the cortex. So here you see much more space for the lips and the head and the hands than many other parts of the body. The other thing you'll see here is also where this information is processed. So you see throat, tongue, teeth, all of these are in that secondary somatosensory cortex, whereas everything else is going to be in that primary somatosensory cortex. So again, it makes sense that things like your hands, your arms, those are things that are more lateral specific. So there's a left side and a right side. Whereas something like your tongue or your throat, it really isn't that way. It's, you have the one. So that's part of the reason you see that difference where you have the lateralization in the primary somatosensory cortex, but not in the secondary somatosensory cortex. So perception is not independent, and information from multiple senses is often used in order to guide one's perception. An example of this is that cats may not respond to birds unless they can both see them and hear them. Also, seeing the skinned knee, in my opinion, often makes the pain a lot worse or better. I don't know if you've ever had that where you skin your knee and you're almost afraid to look at it because if it looks a lot worse, it hurts worse for whatever reason. And if it doesn't look so bad, then it doesn't hurt as much. So it's true that truly these are not independent sensory experiences, they're actually interactions. And these interactions are possible due to polymodal cells, which, as the name suggests, these are cells that have more than one mode. They involve several sensory modalities, and it allows for information to interact so we have more accurate perception of the world around us. So synesthesia, we're going to touch on this a little bit. This is one where it's not easy to figure out what sense synesthesia really fits in, so we put it here, but it's a condition where a stimulus in one modality creates a sensation in another modality. So an example of this is a person may perceive colors when looking at letters or when tasting something or hearing a certain tone. So I have a brief video for you to check this out and see what you think about it. So let me pull that up for you.
Imagine a world where the sound of music made you see colors, where the note of B is sparkling silver, and D flat,
wondrous pure periwinkle.
Okay, well, I just added a lot more.
where the taste of food has a distinctive shape.
Oh, too round.
Well, don't get roasted.
The sound of words can literally leave a bad taste. And thinking of days of the week or months of the year generates an Alice in Wonderland three-dimensional calendar in space.
It's like walking along on a little track.
It may sound a bit strange, but this is the world according to people with synesthesia, where one sense, sight, taste, hearing, touch, or smell, gets jumbled with another, creating what Dr. Richard Saitoic describes as a blending of the senses.
My voice, for example, is not only something that you hear, but also something that you might see or taste or feel as a physical touch.
E flat is turquoise, very warm turquoise.
Laura Rosser sees every note she plays as a distinct color.
F is green. F sharp is yellow-green.
And so while you're playing, these colors, how are they appearing? One at a time as the note is played, or is it like...
They sort of merge into each other.
Synesthesia isn't just people getting a bit poetic about their world. Their brains are wired differently.
Well, they have what I call a different texture of reality.
Hoping to get a better grasp of that reality, I agree to take a couple of simple tests.
Can you see the pattern?
For me, I see the fives. The twos look almost like the fives.
It took me about 15 seconds to find the shape hidden on this page of numbers. But this group of synesthetes who we put to the same test were much quicker.
Can any or all of you tell me where the twos are and what the pattern is?
It took them less than half the time.
Diamond.
And for you, Laura, why was it so immediate?
The twos are orange and the fives are red.
My fives are red and the twos are yellow.
They find it so quickly because Laura Rosser and sisters Evan Lynn and Krista Kostenko see more than just black letters. Since they were children, they've had crosstalk going on in their brains, where every letter is associated with a distinct color, and that color never changes.
Once synesthetic associations are established in childhood, the links stay fixed for life.
So they can't really control it. It's just there. Or
It's something that happens to you. You don't do anything to make it happen.
I see it as a gift, as a sort of spiritual God thing that enables more intuition. It really is an added dimension to what I do.
So that was hopefully a helpful introduction to synesthesia. So what you see is this isn't a disorder. You don't see that the senses are negatively impacted in any way. These are not individuals who have a mental disability. It's just a difference in perception, which is quite interesting. And it does seem to run in families, in case you're wondering about that. So there does seem to be some type of genetic component with it. So now we're moving back to the sensory system of touch. And with this, it's important to know, as many of you will remember from old classes, that skin has three separate layers that you need to know about. You have the epidermis, so that's the outermost layer, and that's the thinnest layer. You have the dermis, which you have home to a lot of the sweat glands and the hair follicles and things like that. And then you have also, this is where the nerve fibers are. And then you have the hypodermis. So hypodermis is beneath the dermis, and this is where it anchors the skin to the muscles and helps shape the body. Now there are 4 types of tactile receptors that perceive touch, and as you'll see, each perceives touch in a slightly different way. When they all come together, they give us the full sense of tactile sensation that we all know and love. So the first one are Messners corpuscles, and these are important for sensing vibration and pressure. They are fast adapting, meaning that they become less sensitive over time to maintain stimuli. So if you have a vibration that stays the same intensity in the same spot, eventually these will stop firing, so you'll stop detecting that vibration. They also have a rather large receptive field, as you can see on this hand here, meaning that each one can detect a rather large area. So they have large vague borders. Merkels disks are very similar to Messners corpuscles, which we'll talk about in a little bit. And they're similar because they're densely packed. They're located usually in sensitive areas, and they have very small receptive fields. So they're very good at detecting very small, precise details. One difference with them is that these are slow adapting, whereas Messners corpuscles are fast adapting. Both have small receptive areas, so they're both used to detect small details. So that's one thing. Another difference is that Merkels disks have an inhibitory surround around that receptive field, which increases their spatial resolution, making them especially responsive to edges and isolated points on a surface. So if you're looking at how someone reads Braille, for instance, it's really these Merkels disks because they're so good at knowing where the edges are and detecting those details. Messners corpuscles are fast-adapting touch sensors that have relatively small receptive fields. Messners corpuscles are much more numerous than Merkels disks, but they offer lower spatial resolution, meaning that they're not as good at detecting small details as the Merkels disks. However, since they're fast adapting, they're actually better for detecting changes. So you'll remember the Merkels disks are slow adapting, so they don't ignore stimulation that is just the same and unchanging as well, whereas these are fast adapting, so with that they ignore things that stay static, which makes them more sensitive to change. And lastly, Ruffinis endings. These are slow adapting receptors that actually measure stretch sensations, and they cover broad areas because of this. So anytime you feel a stretch, it's actually these Ruffinis endings that are responsible for that feeling. So this is just I think this is a helpful thing to look at to kind of help you see the difference between these different receptors and what you'd see if you're reading Braille here. So what you see here is both Merkels disks and Messners corpuscles are very good at detecting these, but you have the Merkels disks being a little bit better, in part because they have that inhibitory surround, so they're really good at detecting the edges of things and the presence and absence. Of course, you don't have too much of a stretch here, so you see a little bit of activity from the Ruffinis endings, but not that much because the skin's not stretching that much. And lastly, you do have some vibrations as your finger moves across the Braille. So you see some vibrations, but as far as actually making out the Braille, it's going to be primarily the Merkels disks and the Messners corpuscles that are really responsible for that. So as we've talked a little bit about previously, the dorsal column system helps deliver touch information to the brain. So what happens is that there are these receptors all throughout the body, and they send axons up via the dorsal column of the spinal cord, where they synapse on the dorsal column nuclei in the brainstem. And then from there you have axons from the neurons in the medulla, which cross the midline and then go to the thalamus. So this is like so many of the other sensory systems we'll talk about. It goes through the thalamus. Thalamus, again, a big relay station for sensory information. And then it goes to the primary somatosensory cortex. And then after that, it goes to the secondary somatosensory cortex, of course. So that's how the information gets from the individual receptors up to the brain, as it goes through that dorsal spinal cord system up into the medulla, to the thalamus, and then to the primary somatosensory cortex. So now dermatomes. Dermatomes are just an area of skin that is mainly supplied by a single spinal nerve. So as you can see here, the different spinal nerves that are associated with different dermatomes. And what you'll notice is, again, this is like kind of like when we talked about the difference between dorsal and ventral and all those things. These are most easily seen when someone's actually laying down, because it goes back almost to our ancestors, our animal ancestors, with how these line up. So it's not the way you necessarily think it would be, just based on looking at a standing person. But what you can see is that each dermatome really does line up with where the those sensory axons are connecting to the spinal cord. So with this, of course, what this means is that sensation at different portions of the body connect to the spinal cord in different places. And this, of course, has significance in reference to spinal cord injuries. So if you have a spinal cord injury, you'll retain sensory information above that injury, but not below it. And this is why. It's because anything above an injury, let's say the injury was here, everything above that will still be intact. So all of this would still be intact. It'd be this everything below it that would not be intact. So, as mentioned earlier, cells in the somatosensory brain regions are arranged by a body surface plan, with areas with more nerve endings having larger areas within the brain. One thing that's kind of cool is that these receptive fields can also be changed with experience. So they actually did an experiment where, for instance, if a nerve to the body region was severed, like for instance, like here, if you had an experiment where you cut off a finger, would that cortical area shrink? And what they found is this actually does happen. The brain, if the sensory is removed, the brain reorganizes so that what was there, that information or that brain region that was there, gets incorporated by other regions, and those regions expand. So in a related study, they actually had monkeys trained to have two fingers touch a disc in order to obtain a reward. And what they saw that was interesting is when they did this thing where you had to touch the disc to get the reward, you actually had a similar change. You had the two fingers that had to touch the disc show increases in the brain region that was associated with the touch. And this is similar to other studies we've talked about with humans, where, for instance, you may remember with the juggling, they saw some, in that video with the juggling, they saw some changes in the brain based upon that learning history. So what this shows is that the brain can reorganize itself, and it does so not just to significant injury like this, but also just to learning or a need to use certain digits or certain parts of the body more. So this is a video, it may be worth watching. I'm not going to throw it in here just because last time I taught the class, there were a couple students that said it was a little too graphic for them. So watch it at your own risk, but that is the link. So pain is obviously an unpleasant experience that's associated with tissue damage, but there are actually people that have this congenital insensitivity to pain, which is a inherited syndrome where they don't feel pain. And on one hand, this sounds great. This sounds like something everyone would want to have. But in reality, it ends up causing quite a few problems because, of course, pain helps us to withdraw from negative situations or times when our tissues are being damaged. And it helps also make sure that we're not engaging in certain activities while our body is recuperating. So with that, there are a lot of signals that we miss out on if we don't have pain. So as you'd see in the video, if you do end up watching it, it leads to problems. So this is a little girl who has this congenial insensitivity to pain, and she has to wear goggles because she'll often accidentally injure her eyes and injure other parts of herself without even realizing it because she doesn't have that pain response, so she doesn't know that she's injuring herself. So how is pain perceived? Well, much like any touch, pain actually has its own receptors that are used to detect painful stimulus. So nociceptors are peripheral receptors that respond to painful stimuli. And often what happens in the skin is actually when there's damaged tissue, it actually releases a chemical that activates the pain receptors in the skin. One example of this is free nerve endings. So these are in the dermis, so that middle layer of skin, and they have specialized receptor proteins. And what these free nerve endings do, they actually look a lot like naked nerve endings, and they respond to changes in chemicals, to temperature, and also to pain. So this is how pain is detected. Much like you have a Merkels disk in order to detect touch, you have receptors such as these free nerve endings that are used to detect pain. So, have you ever wondered why you sweat when you eat spicy food? Or at least I do. It's actually because it's the same receptor that capsaicin binds to that also detects painful heat. So capsaicin is the hot chemical in chili peppers. It makes things taste hot. And so again, the receptor that capsaicin binds to is called the transient receptor potential vanilloid type 1, TRPV1. So this receptor detects painful heat. There's also a similar but different receptor called TRP2, and this differs from TRP1 because it detects even higher temperatures, and it does not respond to capsaicin. But that's why we actually will sometimes sweat when we're eating spicy foods. It's because in a way, we're getting the same stimulation as we would if we were actually hot. So our body responds in a similar way. So we talked a little bit briefly about the TRP2 receptors on the previous slide. So the TRP2 receptors use fast, large myelinated A delta fibers. So information sent along a TRP2 receptor gets to the brain very quickly. So because the TRP2 receptors have these large, fast myelinated fibers and can get information to the brain so quickly, these are often the ones that are utilized when you burn your finger really badly or something like that, something where the signal needs to get through very quickly. Whereas the TRPV1 receptors use C fibers, which are thin, unmyelinated axons that conduct quite slowly, and they actually produce the long-lasting feelings of pain. So, sometimes you get a burn on your finger, and you feel that immediately, of course, and you pull back really fast. But after there's the kind of dull, throbbing pain you have, that would be from these TRPV1 receptors. There are actually also cool menthol receptor 1, CMR1 receptors, which respond to menthol and to cool temperatures, and these are also located on C fibers. So, you may be familiar with Icy Hot, for instance, or things of that nature where you put them on and it makes the skin feel cool for part of the time. Part of how that's done is using this receptor, using menthol, because this receptor responds both to cool temperatures and to menthol, so you're going to have that cool sensation whenever this receptor detects menthol. So the sensations of pain and temperature are transmitted separately by the anterolateral or spinothalamic system. So again, I'll wait on this slide a little bit because I know it's a lot of notes for you to take. So they travel separately, both pain and temperature, and they cross sides in the spinal cord which is different because the other sensations cross in the brain. So one difference between pain and other touch sensations is they cross in the spinal cord. The peripheral fibers use glutamate to excite the spinal cells in the dorsal horn. They also release something called substance P. Substance P is called substance P because it's actually a peptide, so that's where the P comes in. And this substance appears to be really important in processing pain sensations. There have actually been studies of mice, for instance, who have had substance P knocked out, where they're no longer sensitive to substance P. And what was found is that they were unresponsive to certain types of intense pain. So again, if you don't have this, you can have some of that pain and sensitivity like we talked about previously. So neuropathic pain or phantom limb pain may be due to the inappropriate signaling of pain by neurons. So what will sometimes happen is that if you have an amputation, you can actually get it where even long after the amputation healed, you can still have this nerve pain where these pain receptors are firing and you're still getting pain from the limb that you no longer have. And so as it says, you have these dorsal horn neurons that can become hyperexcitable, and it causes chronic pain. Now, what's really cool is how this can be treated. So, remember how we talked about earlier, how when you scrape your knee, sometimes you look down and you realize that it's not as bad as you thought it was, and that changes your perception of pain. Well, the same thing can actually be done here. So you can actually have the person use a box like this where they put both arms in a box, but you have a mirror. And for the person standing here, you have this here blocking their vision of their amputated arm, and the mirror making it appear like they have two intact arms. So with this, the person does this, and it helps actually treat the neuropathic pain because it signals the brain, oh no, this arm's actually okay. These are pain signals that we should ignore, and so because of that you start to ignore those pain signals, which is really cool when you think about it. So that's one way that phantom limb pain is often treated. So pain can be debilitating. It's a blessing in many ways, but it can be debilitating for a lot of people. So because of that, finding medications or finding strategies to treat pain is essential. So here we're looking for medications that have what we call an analgesic effect, meaning that they reduce or eliminate the sensation of pain. So as we've discussed, opiate drugs such as morphine or Dilaudid are very effective in treating pain. Additionally, the body has endogenous opioids that help reduce pain naturally. So again, opioids, as the slides say, are endogenous opiate-like peptides in the brain, and they can be released in order to help reduce the feelings of pain. And they, of course, interact with opioid receptors, which are the receptors that either are activated by these endogenous peptides or by opiate medications like Dilaudid. Transcutaneous electrical nerve stimulation, or TENS, has also been used. And here, what happens is it delivers electrical pulses to the skin in order to help relieve pain. And it's actually been shown to relieve pain that is otherwise hard to control. We're not exactly sure why this works, but what it looks like happens is that endogenous opioids play a role. And we think this is the case because giving a patient naloxone, which blocks the opioid receptors, also blocks the analgesic effect of the TENS unit, suggesting that these natural opioids are playing an important role in treating the pain-reducing effect observed with using a TENS unit. Placebo, of course, also comes into play with pain relief. In a study comparing placebo to morphine, a full 1/3 of the patients experienced significant pain relief with the placebo. So, is this effect just in their mind? No, it actually doesn't seem to be, because this was also done with tens, and giving the patient naloxone eliminated the effect. So thus, what it appears happens is that in some individuals, giving a placebo likely causes the endogenous opioids to kick into effect. And much the same way, you can block it with naloxone. Also, acupuncture has been around and been used for pain relief for at least 3,000 years. And similar to other methods we described, at least part of its effect appears to be due to endorphins, because when you give naloxone, again blocking those opioid receptors, it significantly reduces the effect of acupuncture. So that isn't to say that it doesn't have an effect beyond the endorphin release, but it appears that the endorphin release, the endogenous opioid release, is a major contributor to its ability to help treat pain.